Services Administration. The ATTC network is comprised of 10 regional centers, 4 national focus area centers, and a network coordinating office. Central Rockies ATTC Region 8 provides trainings and technical assistance to North Dakota, South Dakota, Montana, Wyoming, Colorado, Utah, in collaboration with our partners at University of Nevada, Reno, and University of Iowa. All participants will be muted for the duration of this learning series webinar. In order to have the best sound quality, we recommend you use the call-in number provided located in the upper right-hand corner of your screen rather than the speakers in your computer. If you are experiencing any technical problems during this learning series webinar, please email Shannon Christensen at shannon.christensen, that's CHRISTENSEN, at utah.edu, or please call toll-free 855-801-4237. Please use the chat feature located at the bottom of the screen to ask questions during the presentation. If time permitted, questions will be addressed at the end of this webinar. Otherwise, attempts will be made to follow up by email post-webinar. This webinar will be recorded and posted to Central Rockies ATTC website September 1st of 2015. Additionally, a copy of today's PowerPoint presentation is located in the handout section on your webinar toolbar. Instructions on how to complete the post-webinar test to receive continuing education is in the handout section on your webinar toolbar. It is also available on the Central Rockies ATTC website under Continuing Education. So now I'd like to turn the time over to Dr. Kimberly Payton. Thank you.
Good morning, good afternoon, and welcome. I am Dr. Kim Patton with the HRSA Office of Regional Operations, and I'm excited that you have joined the Region 8 Public Health Learning Series today entitled Strategies to Address Opioid and Prescription Drug Misuse. This is a 5-part webinar series brought to you by a collaborative effort from the Central Rockies Addiction Technology Transfer Center and the Denver Regional Offices of the Health Resources and Services Administration, or HRSA, and the Substance Abuse and Mental Health Services Administration, or SAMSA. With me here today is Dr. Charles Smith with SAMSA. The goals of the learning series are to increase knowledge and practical skills related to safe clinical practice guidelines for prescription medications, the clinical treatment of addictive disorders, and the use of naloxone for opioid overdose. And I wanted to remind everyone that if you want to ask questions during the presentation, you'll need to use the chat feature at the bottom of the screen. Time permitting, questions will be addressed during the webinar. Otherwise, attempts will be made to follow up by email after the webinar. Today is our second presentation in the learning series, which is focused on clinical assessments. Prescription drug abuse has been categorized by the Centers for Disease Control and Prevention as an epidemic, and providers must learn how to effectively screen for and manage chronic pain and prescription drug abuse. The learning objectives for today's webinar is to be able to describe effective clinical assessment and screening practices with a focus on the assessment of pain and substance use, particularly in primary care settings. Today we have 2 wonderful speakers in the fight against opioid addiction and prescription drug misuse. Carolyn Swenson will be one speaker, and she is the Manager of Training and Consultation with SBIRT Colorado within the Peer Assistance Services Organization. Carolyn Swenson has a clinical background in public health nursing and maternal and child health nursing. And our second speaker is Dr. Mary Weber. She's an associate professor with the University of Colorado College of Nursing, and she has a clinical background as a psychiatric nurse practitioner. Okay, now I'd like to hand off the webinar presentation to Carolyn Swenson and Dr. Mary Weber.
Good morning, everyone, and welcome. This is Carolyn Swenson. I'm going to start us off and then turn the presentation over to Mary Weber. I would first of all like to acknowledge my employer, Peer Assistance Services Incorporated, with more than 30 years of all associated with substance abuse prevention and related issues. I would also like to acknowledge SAMSA for 2 consecutive 5-year grants to the state of Colorado to implement routine screening and brief intervention across our state.
Please advance the slide. Please advance the slide. We would also like to acknowledge, one back please. We would also like to acknowledge that the University of Colorado College of Nursing has a Samsa grant from the Centers for Substance Abuse Treatment that supports the work of myself and my team members, Paul Cook, Laura Agard, Laura Rosenthal, Farrah Bowler, and Lisa Krug-Avery. The College of Nursing has partnered with peer assistance to integrate SBIRT into our undergraduate nursing and our graduate nurse practitioner advanced practice nursing curriculum. Please advance the slide. Our objectives for today, in addition to what Kim has said, is to identify importance of screening for substance use and mental health as a part of opiate use prevention. We're going to be describing screening tools for substance use, mental health, and pain in primary care settings. We're going to be describing screening, brief intervention, and referral to treatment or SBIRT for alcohol and other drugs. Identify team-based approaches to screening and intervention for substance use and mental health, and to, at the end, describe training and implementation resources. Please advance the slide. So why address substance use and mental health in primary care? Well, in this topic of opiate use and chronic pain, we know that there's often a vicious cycle. Chronic pain either exacerbates or comorbid with trauma, worsens or comorbid with depression, anxiety, starts, worsens, comorbid alcohol, drug use, tobacco use, which worsens chronic pain, which worsens trauma, worsens depression, and you can see the cycle goes on. So we know that there is a significant number of comorbidity with trauma, depression, anxiety, mental health, and substance use disorders with chronic pain, and we believe that if we address and treat these comorbid psychiatric and other risk factors, we're going to improve pain management overall and decrease the risk for multiple adverse outcomes such as misuse of prescription medication and other substance use functioning and poor functioning in all areas of life. Next slide, please. So opiates and substance use. It's interesting, some of the data that we have. In 2012, the American Society of Interventional Pain Physicians published some guidelines about responsible opiate prescribing, and I wanted to share some of the conclusions which I thought were quite interesting. Some of the evidence supports that the use of long-acting opiates or a combination of both short and long-acting opiates in chronic non-cancer pain has contributed to the increased use of emergency room visits and the increased death from overdose. So it's pretty significant. Next slide, please. There is good evidence also, and this is probably the most startling, that 60% of the deaths from opiate overdoses are from when opiates are prescribed appropriately. And I think that's probably a shock for most providers, as that there is an assumption that most of the deaths are from misuse. So the majority of opiate deaths, at least from the current data, shows that these deaths are from opiates prescribed appropriately. However, 40% of opiate death fatalities occur in only 10% of individuals diagnosed with some type of opiate or other substance use disorder. So this means that most overdoses are in individuals who are not diagnosed with a substance issue, but those that have a substance-related issue, an opiate use disorder, are at high risk for overdose. So we have a lot of speculation, especially clinically, about why this occurs. And there is quite a bit of speculation from a clinician perspective that there may be some interactions with these appropriately prescribed opiates and interactions with alcohol that's used, marijuana, other drugs, as well as mental health issues, which is why we're having this conversation. So we'd like for providers who are prescribing opiates to consider screening for depression, for anxiety, for trauma, for intimate partner violence, as well as tobacco, alcohol, and other drugs, illicit or legal, and in Colorado legal includes marijuana, as well as non-medical prescription drugs, meaning we're using them for psychiatric purposes, such as drugs like quetiapine or other drugs that are very sedating, have other uses, and will be very much a significant drug interaction with opiates that are used. So we've included some validated screening tools for primary care. And these are suggestions on screening tools to consider. There are quite a few options, and we have a tremendous amount of resources that we've put at the end of the slides. But this is something to consider. And most of these are in the adult population. They've been validated in the general population of adults, not in a substance or mental health population. They're generally short. They can be self-administered by patients, which is the most efficient. Some often have a brief pre-screen, such as the PHQ-2, which is the Patient Health Questionnaire 2, is a 2-screen as opposed to a PHQ-9, which is the bigger screen, or an Audit C, which is a smaller screen for alcohol as opposed to the bigger Audit, which is a bigger screen for alcohol. So once we have a positive on these screens, then they need to be followed up with further assessment. Most of these are in the public domain and can be embedded in EHRs, or you can certainly use them in a paper fashion and then record the score in an EHR setting. These self-administered by patients can provide very good results and a very good stepping stone to discussion. So some of these, if you're not familiar, the PHQ-2 or the PHQ-9 is very common and seen in primary care for depression. The GAD-7 for anxiety disorders. So the SAFE, or the Safety and Suicide, is less of a screen and more of a guide for clinicians. And what this is it kind of leads the providers to look at what are the risk factors for suicide when someone screens positive for any risk, or when someone is potentially at risk and you want to look at also resiliency factors. So this is a really nice guide to have. The Edinburgh Postnatal Depression is well known in pregnancy-related depressions. The Audit, or the Audit C, in looking for alcohol use. The DAST for drug use. Marijuana is the QDIT-R, which is the Cannabis Use Disorder Identification Test. And one of the nice things to look at, and that can be embedded in, and this includes the child settings as well, is the adverse childhood experiences. The adverse childhood experiences is a very nice predictor of someone who's going to be at risk, potentially at risk for substance use disorders or mental health disorders, and this can be given in adults. And then for PTSD, there is a nice screen that's actually, this is part of the veterans screen, which is primary care PTSD. We also have other primary care screens that can be used, as well as there are multiple screens for intimate partner violence. Screening for pain is also very important, and we did a little research and found that the most common scales for screening are the numerical rating scale, meaning please give me a rating on a 1 to 10 scale, 10 being the most pain, 1 being, or 0 being no pain. The visual analog scale, which has them look more on a Likert scale and have them pick on a Likert scale where they are. A verbal rating scale, meaning person rates this as mild, moderate, or severe. And then the FACES pain scale, which is also commonly seen in children. These are the most commonly used measures of pain intensity, and I've included a review of these scales in your reference section. The most support emerged, interesting enough, for the numerical rating scale, and being able to detect that being the most responsive for pain and changes in pain response, and looking at sex differences in pain intensity. So I think the message here is that substance use is a continuum. We want to reduce the stigma of talking about substance use as only a mental health disorder or a substance use disorder. We want to look at substance use as really a public health issue on a continuum, from normal use to excessive use to risky and unhealthy use. And the SBIRT model that Carolyn will talk about in a moment here recognizes this full continuum of substance use and resources for assessment, screening, and intervention.
Okay, so I'm going to talk about screening, brief intervention, and referral to treatment, also known as SBIRT. This is an evidence-based prevention service, particularly designed to address at-risk alcohol use and intervene early in order to prevent or reverse adverse health and other consequences. It's a highly underutilized service, but adoption of SBIRT is growing, which is a good thing across the country. As with other chronic conditions, such as cancer, cardiovascular disease, diabetes, and others, we know that earlier intervention to address alcohol and other drug problems is likely to improve health and other outcomes. Yet typically in healthcare, historically, we've missed opportunities to intervene early. Screening and brief intervention for alcohol is one important approach to earlier intervention. These next few slides describe the burden of alcohol-related problems in the United States. At-risk alcohol use is by far the most prevalent substance use problem in the United States.
Please advance the slide.
These data on alcohol in the next 3 slides are on alcohol use among adults in the United States, collected by the Centers for Disease Control and published in 2014. We know that nearly 38 million adults in the United States drink too much alcohol. Next slide. Yet, fewer than 5% of those who drink too much meet criteria for an alcohol use disorder, according to the DSM-5. Next slide. We also know that only about 1 in 6 adults report that they've ever spoken with a health professional about alcohol as a routine part of their health care, and this is our missed opportunity. Next slide. Unhealthy or at-risk alcohol use is typically described in 4 primary ways, and some people, of course, may exhibit more than one form of unhealthy alcohol use. First of all, unhealthy alcohol use is binge drinking or heavier episodic drinking. It is also higher weekly use than what's considered low risk. It's any alcohol use during pregnancy. Fetal alcohol spectrum disorders are still the #1 preventable birth defect. And finally, it's any alcohol use under age 21. The developing brain up to about age 25 is very vulnerable to the adverse effects of alcohol and other drugs. And in fact, the majority of individuals who develop a substance use disorder during their lifetime, including tobacco, alcohol, or another drug problem, develop that problem during adolescence or early adulthood. Next slide. So patients are often not aware of what we mean by lower risk drink limits. And this slide describes what has been shown in research to be lower risk limits for men and for women. And this can be a very useful tool in discussions with patients to talk to them about potential harms associated with exceeding lower risk limits and things that may already be happening in their health or other areas of their life related to heavier or problematic drinking. So lower risk limits for women are up to 7 drinks in a week and no more than 3 on any occasion. Lower risk drinks for men are up to 14 drinks in a week and no more than 4 on any occasion. And an occasion is generally defined as in a day. And then, as I already mentioned, any alcohol during pregnancy or under age 21 is considered at-risk drinking, and there are several other types of health and other situations where people are advised to abstain from alcohol, including for the potential of interactions with a number of medications. Next slide. Patients may also not be aware of what we mean by serving sizes of alcohol. So this is one simple depiction of standard drink sizes. Each of these servings contains approximately 14 grams of alcohol. A standard 12-ounce beer, standard 5 ounces of table wine, and 1.5 ounces of distilled spirits or liquor. This slide depicts what's known as the alcohol use pyramid. It describes the pattern of alcohol use in the general adult population of the United States. About 70% of adults either abstain entirely from alcohol, or if they drink alcohol, they drink at what are considered lower risk limits, which were just described in the previous slides. Only about 4 to 5% of adults, or the tip of this pyramid, have the most serious level of a problem associated with alcohol and would meet criteria for an alcohol use disorder. It's the 25%, or the middle of the pyramid, who are the adults who exceed weekly or occasional limits, or in other words, drink at at-risk levels. Some are at risk for health problems, and others may already be experiencing health or other consequences associated with their drinking. And this is the primary target population for alcohol screening and brief intervention. This is, in other words, secondary prevention or early intervention to prevent consequences of risky drinking. So this slide summarizes the three components of what's known as SBIRT, or screening, brief intervention, and referral to treatment. Step one is to screen patients using one or more validated screening questions. Screening can be accomplished accurately with even one brief screening question that I'll describe in the next slide. A positive brief screen can then be followed by further screening with a short questionnaire, such as the audit, as Mary already described, to help identify actual level of risk. Step two of the process is a brief intervention. The brief intervention is simply a short conversation between a health professional and a patient that can last from a few minutes to more than 15 minutes, depending on patient circumstances and time. Multiple brief interventions are likely to be more effective than a single brief intervention, especially when you're in a primary care setting and you have a relationship between the health professionals and the patient. And finally, step three is referral to treatment. When screening identifies a more serious problem, such as a possible alcohol use disorder, the goal is to motivate a patient to seek further assessment and appropriate services, such as treatment. One brief motivational conversation may not accomplish it, but could start the process to helping to connect a person with more services. So what is the evidence for screening and brief intervention for alcohol? The United States Preventive Services Task Force issued a grade B recommendation for alcohol screening and brief intervention in adults. This means that this prevention service should be offered routinely in primary care settings. Routinely has not been defined, but it's generally understood to mean at least annually, although screening can be done at every patient visit, similar to tobacco screening. In addition, a report from the Partnership for Prevention concluded that alcohol screening and brief intervention is one of the 4 most effective preventive services in terms of preventing death, injury, and disease, and is one of the most cost-effective services to deliver as well. Next slide. The United States Preventive Services Task Force determined that there is insufficient evidence, back one slide please, to recommend drug screening and brief intervention as a routine prevention services. However, screening to identify marijuana, illicit or illegal drug use, and non-medical or inappropriate use of prescription drugs is still critically important in order to make accurate diagnoses and to understand a person's risk factors and history. Individuals with problematic drug use will typically require more intensive interventions and different types of interventions beyond a single or multiple brief motivational conversations to help them change. This slide describes one approach to very brief screening for alcohol. Even the first question on this slide, how many times in the past year have you had 5 or more drinks for a man, 4 or more drinks for a woman, has excellent specificity and sensitivity for identifying at-risk alcohol use. And 2-question brief screening is presented on this slide, with the second question being, how many drinks do you have on average in a week, with 15 or more being positive for a man, 8 or more for a woman, can be a very efficient way to identify anyone who has a risk for at-risk alcohol use. And this can then be followed by further screening with a tool such as the audit. Next slide. This is the question that is most often used to begin the process of screening for drug use. In the past year, have you used or experimented with an illegal drug or a prescription drug for non-medical reasons? And any person who responds yes would be considered as having a positive screen, and that screening, brief screening, could be followed then with further screening with a tool such as the DAST or the QDIT or another screening tool. This slide just again touches on several of the screening tools that are most commonly used and tend to be very efficient in primary care settings. The audit for alcohol, DAST for drugs, QDIT-R for cannabis use disorders, and sometimes, but less commonly, the ASSIST. For those patients who screen positive on brief screening, at the very minimum, it's important to interpret the results for the patient, to provide some feedback to them about lower risk drink limits or any concerns associated with their use of drugs. Ideally, patients who screen positive will also receive what's known as the brief intervention, which is simply a short conversation with the patient's permission that can last as few as 5 minutes. Next. The goal of the brief intervention is to raise a patient's awareness about alcohol or other drugs and health, to link their current use of alcohol or drugs to health problems they may already be experiencing or the risk of future problems, enhance their motivation to cut back or quit drinking altogether in some cases, or quit using drugs altogether, and then negotiate next steps for behavior change. Next slide. The brief intervention utilizes principles and techniques from motivational interviewing. And when we teach clinics how to do screening and brief intervention for alcohol, we focus on this particular approach to a brief intervention, known as the brief negotiated interview. This is a structured, stepwise approach to having this conversation with a patient. It can be carried out in a few minutes, and it is relatively easy for the healthcare team to learn, even those who have not had a lot of training or experience with motivational interviewing. The 4 steps are outlined on this slide, and we will introduce a resource later in this webinar that can help guide the delivery of a brief negotiated interview conversation with a patient. So step 1 is simply to raise the subject with the patient's permission to offer feedback and information. When providing feedback, to give a little bit of personalized information and then always elicit the patient's response to that information by asking something like, so what do you think about this information about alcohol and how it could affect your health? Step 3 is to utilize several techniques from motivational interviewing to enhance a person's motivation to cut back or abstain, to change their pattern of alcohol use. And step 4 is to negotiate with the patient collaboratively next steps and advise them and assist them in the help they may need to make a change. And at this point, I'm going to turn over with the presentation to Mary.
So the final part of SBIRT is referral to treatment. And what we've found is that most providers would like to do this, but feel uncomfortable or feel that they don't know what resources are out there. And so this is a very difficult step, as most providers will screen, but less than half of those that need further referral may actually get this referral. And so this is the part that I want to spend just a few minutes on. We have provided some resources at the end of these slides. One of them in Colorado, this is based on peer assistance work, is the linkingcare.org, which is a great website for looking at what kinds of services, whether they're mental health or substance services, based on location, based on insurance, based on lack of insurance, based on provider preference, male, female, those kinds of things, and being able to actually link them up, which is the idea of linkingcare.org. Samsa also has a national treatment finder, which is also a wonderful website to have handy. And it's really nice to be able to engage the person once you've had this discussion and once you've begun this elicit, provide elicit motivational interviewing early technique, we have the person's interest. Here is a chance that we have to do what's called a warm handoff, to be able to then give them a referral to an appropriate place. The worst thing we can do is refer someone to a place, one that no longer takes patients, that has closed up, won't accept their insurance, has a waiting list, and then the person is very disappointed and somehow the motivation falls backwards. So it's really important for us as providers to follow through with this part of the step. So who is the person that gets referred? Well, we're thinking about who might we, as a primary care provider, refer to a mental health provider or a substance treatment provider. That might be a person that has a pattern of binge drinking, has a pattern that has excessive binge drinking. It's not just once every 6 months during a holiday, but has more of a pattern of drinking that you are seeing a significant problem with. A person that has risky illegal drug use. So we have someone that is potentially using opiates, excessive opiates, meaning that they're going to multiple providers. They may be going on the street to get cocaine or to get methamphetamine or ecstasy. And so this is very risky, illegal drug use, and part of the risk is obviously the actual drug use. But the other piece of this is that they're in very risky situations where they have a risk of being assaulted or raped or murdered. And so this is a conversation to have with them as well, that this may be a person that would benefit from talking to a mental health provider or a substance use provider to talk about that. The other piece of this would be habitual marijuana use. Now, in Colorado, marijuana is legal. But if it is to a point where we're seeing marijuana use where the person no longer is able to hold a job, no longer is able to care for family members, participate in relationships, then we're looking at consequences from legal drugs just as we are with alcohol. So these are individuals that we would like to at least have someone else to talk to. In a busy primary care practice, this is not usually able to be done, but this is what would be perfectly appropriate to talk to a behavioral health provider or a substance treatment provider. So another person to consider for referring is a person that's already experienced serious consequences of alcohol prescription, legal and or illegal drug use. So this comes into the heading of opiates, and this is a person that potentially has had some adverse side effects. They may be drinking alcohol and using the opiates that are prescribed, drinking alcohol, using opiates, and borrowing benzos from from a neighbor or a family member. And so these are the things that we are assessing as we're looking at their use. This becomes potentially serious consequences, whether we can see a series of problems with breathing or emergency room visits. And so they've already experienced consequences. They may have had a DUI or some other legal piece. That this is a person that clearly needs to be referred for additional work. And as Carolyn said, from the SBIRT perspective and the evidence, we don't believe and we haven't seen the evidence that, yes, we can take someone with serious consequences of these substances and use a one-time screen and feel that we've done, that we have them on the road to recovery. We have a good start, and this is something that we consider, but this is usually an individual that takes multiple interactions and usually work in other areas, which is why we're looking at assessing for mental health as well as substance use. And then obviously someone that meets criteria for a possible substance use disorder. So these are individuals that often have withdrawal from opiates or withdrawal from alcohol, withdrawal from cocaine. These are the individuals that will tell you, I have tried to stop but can't. And these are the individuals that do need help and quickly. They may be in a place where they are now ready to consider this, but because of the physical dependence that they have on the substances, are not able by themselves to be able to stop. These are individuals that we can help and that we can intervene quickly and get them into appropriate treatment settings. Next slide, please. So how does this work in real life? So we wanted to talk a little bit about team-based care or integrated care and how this might work in a primary care setting. Next slide, please. So we don't have time to go into many models of integrated care or team-based care, but we do want to talk about this as how this might look in primary care settings. So we have the in-person interdisciplinary team. And so this is generally when people on different disciplines are co-located or located in the same clinic. And when we're talking interdisciplinary, and I'm not saying this in any order of hierarchy, we're talking about nurse practitioners, physician assistants, psychologists, physicians, certified addiction counselors, licensed mental health counselors, social workers, health educators, medical assistants, and community health workers, and as well as peer workers. And so we have a number of, or one or many of those individuals in the team that may be co-located in a single clinic. And that's one model. Another model, and in fact Colorado is looking at this as some pilot demonstration, is what's called a virtual interdisciplinary care. And we're looking at this, and this would use such capabilities as telehealth or some kind of immediate phone consultation that the primary care provider would have to either a substance treatment provider or a behavioral health provider to be able to guide the primary care provider in knowing what to do with, if they screen positive in a certain way, what to do with this information. And then we have coordinated care delivered at different locations by different types of providers. This is obviously the most common. This is what's happening for the most part now, and this has led to some fragmented care. It can work, and it can work well, and we'll talk about how that can work well, especially when you can't have a co-located or a virtual setting to facilitate this team-based care. So integrated or team-based care looks at the whole person. And having the privilege of working in an integrated care setting and facilitating the development of primary or integrated care settings, I can tell you that the most important piece of this is great communication between providers. This is the most important and the most difficult because it requires both written and verbal between members, and so getting EHRs to communicate can be quite a challenge, especially given HIPAA and other regulations. And so this becomes probably one of the biggest challenges to integrated care that we have right now, and one of the things that we're working somewhat the hardest on this piece. So what this means is identifying who does what. And we'll talk about that in a minute. But communication amongst providers is integral to facilitating the coordination of care and not having fragmented care. So what this also means is that primary care takes on mental health screening for depression, for anxiety, for trauma and substances as routine care. As Carolyn talked about, is that we really need to be in the business of prevention and early intervention. And so early intervention piece of this is identifying at-risk or risky behaviors, at-risk individuals, and those that need further intervention. And so this is done with the screening that we talked about. The next piece of this is the communication of what happens next on a team. And this is the other challenge that we work on as a team, and decision trees or algorithms developed and agreed upon by the whole team as to who does what with the results. So what type of individual with, say, a co-occurring mental health disorder or a substance use disorder or at-risk behavior is treated by primary care? Who is at risk or needs a consultation with mental health but is treated by primary care? And then who and what type of individual needs to be treated primarily by mental health? And then what type of provider and what type of patient needs to be treated by multiple providers? And this is the case oftentimes with individuals with chronic pain and co-occurring substance or mental health disorders. These individuals are treated best in a team, and in a team by those that are providing the treatment for their chronic pain, as well as providing the treatment for their mental health and or substance issues. And so it's very helpful in these situations to have providers communicating and co-treating and knowing who does what. And as I talked about, referral, and as a basic piece of SBIRT, is that warm handoff. It's best done when, and this is why the co-located works so well, is when you can walk down the hall and say, can you see this person now, or can you see this person in an hour? That obviously works best. That does not work for the majority of primary care settings at the moment. And so we have to look at how we provide a warm handoff. And so that may mean someone in the clinic, whether it is the nurse or the MA or someone in the clinic, does the legwork to find out who is the provider that this person could actually see and to facilitate an appointment for this. Carolyn's going to talk a little bit about resources and training.
Okay, so the final part of this presentation will focus on a number of resources that you can access, we hope quite easily, to learn more about the things we touched on briefly today around screening, how to intervene with patients, and how to move in the direction of more integrated care. And for those who would like training, we have a couple of options for training as well. So on the next slide, you'll see a number of resources for identifying screening tools, including the tools we've summarized in this presentation. Samsa, HRSA, of course, has an excellent website with a lot of information and the ability to download tools for screening on depression, anxiety, alcohol, drugs, and other issues. And so that website is listed for you. For pregnancy-related depression and accessing the Edinburgh depression screening tool during pregnancy and postpartum, this tool would be advised among that population. There's a website for that. The Safety Suicide screening tool that we described briefly can also be accessed through the SAMHSA website. For those who feel it would be beneficial to identify an adult patient's history of adverse childhood experiences or traumatic experiences, we can point you to the ACEs study and the ACE screening tool that can be used efficiently in primary care settings through the acestudy.org website. We mentioned that there are a number of screening tools available to assess for intimate partner violence, and no one tool on this particular topic has emerged as the best, but the CDC has a listing of screening tools as well as good information to help a primary care setting identify what tool is going to work best in the type of clinic that you work in and with the population that you work with. And then also, finally, there's a website for accessing screening tools, especially those that would be appropriate for primary care to assess PTSD. Next slide. So one resource we want to point out for implementing screening, brief intervention, and referral to treatment in a primary care setting is the CDC guide that was developed and released about a year ago, known as the Planning and Implementing Screening and Brief Intervention for Risky Alcohol Use tool. This is a very nice document. It covers everything from planning your implementation and identifying which staff to utilize in screening and brief intervention, which tools to utilize, how to screen patients, how to identify the most appropriate staff to deliver brief conversations or the brief intervention step of SBIRT, how to train staff, how to plan a workflow, which is critical, so that everyone understands from the front desk to the back office who plays what role in delivering this prevention service routinely. And then there's also information to guide conversations and discuss alcohol risks with different types of patients, such as women of childbearing age, older adults, conversations to prevent injury related to alcohol use. So we highly recommend that tool. It can be easily downloaded and used by the whole team. The next couple of slides are going to describe a couple of resources we have developed in Colorado to guide our implementation of SBIRT. First is the SBIRT Colorado poster. We find that this is a very useful tool to post in clinics or other healthcare settings to provide education to patients, but also to guide conversations with patients. It very simply describes what is considered lower risk drink limits for men and for women, and what are serving sizes of alcohol. Both critical pieces of information to identify those patients at risk and guide the early intervention that could be making such a big difference in preventing problems related to alcohol. The next slide describes another tool that we almost always use in guiding implementation of SBIRT. This is what we call our pocket card. It's a tool that describes, again, for the health professional and in conversations with patients, you could show this to a patient, what are lower risk drink limits, what is a serving size of alcohol, and at the bottom of the first page of the card is a 0 to 10 ruler that can be used in the conversation to assess readiness, importance of change, confidence to change. And on the reverse side of the card is a brief outline of how to have this brief conversation using the brief negotiated interview model.
And in working with our students, this is probably one of the most effective tools that they have voiced has been very effective. It takes kind of the heat off you as the provider into here is some information, and it gives the provider then, on the back, just a little bit of a reminder of, okay, what is it that how is it I want to communicate? This by far has been the most successful for our students in working in the community.
And on both of these tools that I just described, you are welcome to contact us if you would like to possibly use these tools in your own work, in your own clinical settings, to talk with patients about alcohol. Mary already described the Linking Care website. This was developed through the SBIRT initiative in Colorado to respond to the very legitimate concern that we were hearing from health professionals across the state about, if I do identify a patient or a family that needs a higher level of care, more intensive services for alcohol or drugs, how do I help connect them to services efficiently and effectively? So although this database is particular to Colorado, it may be worth looking at to give you some ideas for how databases could be developed in other states. The beauty of Linking Care is that it's geographically searchable. You can search by zip code, address, judicial district, etc., to identify treatment services that are reasonably available or close to where the patient lives. And we do know in our state, and probably the case in other states, that there are not enough services. And yet this can certainly help identify what services are out there, what patients are eligible for those services, and what forms of payment are accepted. Then, Mary, also on the next slide, you will see the Samsa Treatment Locator website. This is another excellent website to help you identify services for patients who need substance use treatment. And then on the next slide, we've listed a website that is available to those who would like training, especially on how to put screening and brief intervention for alcohol and other drugs into practice in your setting. And actually the techniques of screening and brief intervention for alcohol and other drugs are very similar to the screening and brief intervention process for any substance or mental health related issues, such as screening and brief intervention for tobacco or for depression. So we recommend that as a place to look for a trainer, and some regions do not have a whole lot of trainers listed in this website, but you're welcome to contact us after this webinar if you'd like help finding training resources in your region. The next slide lists some resources on guiding safe opiate prescribing, and I'll have Mary talk about this.
I want to strongly recommend the Clinical Challenges in Opiate Prescribing that was published in 2014 by Peer Assistance Services. It is open to the public and it is in a PDF form. What's really nice about it is that not only does it take you as a a prescriber of opiates through the process of pain assessment, but it also looks at what other assessment needs to be done. And then what I really particularly like about this is it has a nice algorithm of decision making. What happens when the patient has this challenge or this challenge? And so I think it's a wonderful resource for prescribers. Both of these are really great, but that particularly I think is very much up to date. Next slide, please. These are additional resources. We talked a little bit about some of the studies that we've looked at, and so we just wanted to give you those websites and those references. Next slide.
And this is our final slide, and we thank you for joining this webinar today, but we also welcome your questions. And at the top of this slide, you will see the SBIRT Colorado website, improvinghealthcolorado.org. You can access information about our SBIRT work across Colorado, some reports on outcomes of our work, as well as some of the resources we've listed, and even some of the data that's being collected in Colorado around alcohol and other drug use. And so feel free to contact us after this webinar.
Thank you, Carolyn and Dr. Weber. That was excellent information. I also wanted to thank you for mentioning the Samsa treatment locator, which has recently begun including HRSA-funded clinical sites such as health centers. So it does provide more information than just behavioral health clinical sites. I think we have time for maybe one or two questions. So I'd like to ask if those could be, a few of those could be read and the presenters could have an opportunity to respond.
It looks like we actually do not have any questions at this time.
Okay, thank you. Let's go ahead. Here's our last slide. I also wanted, before I talk about this one, I wanted to remind people that you can access the PowerPoint presentation as well as continuing education information in the handout section of this webinar toolbar. The first item there is the PowerPoint presentation, and the second item is information on continuing education. That continuing education information, which includes how to access the post-test, is also available on the Central Rockies ATTC website under continuing education. So if you look at this last slide here, we have 3 more webinar presentations next Wednesday, same time. Appropriate opioid prescribing, which gets into the opioid clinical guidelines and the use of prescription drug monitoring programs and electronic health records to enhance clinical decision making. On August 12th, we're going to get into treatment of opioid addiction, and the learning objective is to recognize effective interventions and resources to address opioid addiction. And then lastly, on August 19th, 11:30 Mountain Time, we'll have opioid overdose intervention and drug disposal strategies, 2 very important topics in the effort to combat this epidemic. I'd like to thank everyone for their participation in today's webinar, and just see if the presenters or Dr. Charlie Smith here from Samsa has any final comments. Hearing none, again, thank you for your participation, and we look forward to next week's webinar.